Good morning and welcome to all of you from the College of Public Health, Chulalongkorn University and the University of Georgia. My name is Methari Panyangarakun as a family physician and pediatrician. I will make this presentation about 20 minutes. My talk will be divided into 3 sections about our area and district, about our hospital and primary health care system and the hospital financial structure. Our district has population about 1,020,000, 1,025,000. We have 15 sub-districts, 140 villages, 2 municipalities. In our community, we are general hospital and have primary care unit, 25 health stations, 58 temples, and the additional child care center, primary school, secondary school, and college. In terms of demographic structure, we have seen an increase in elderly from 13 to more than 20%. This is why we must recognize that we are heading towards an aging society. Now I present some facts regarding our hospital. We are a general hospital in level M1 or A in 5 region health region with 300 beds, average 1,000 patients a day and 200 inpatients a day. We can manage 5 operating rooms and 9 to 10 dental tasks. The administrative structure is led by Dr. Minnat Mukdi and as director and as a team. We have about 700 personnel and including 43 doctors and 10 dentists. The top 5 most common diseases among inpatients are pneumonia, cerebrovascular disease, heart disease, and also cancer. As part of district health system, we have networking partners who are encouraged to participate in the activities according to specific fields such as maternal and child health club, youth volunteers, to build on student health leaders in school, health worker, temples, administrative structure, and also health volunteers and private sector. Our main health issues is divided into communicable disease and non-communicable disease. The following are examples of communicable disease such as dengue, tuberculosis, and pneumonia, and non-communicable disease, diabetes, hypertension, teenage pregnancy, and also road traffic injuries are the most prevalent issues. We have 3 service designs in healthcare and primary healthcare system. The first design is primary care unit, which is a unit for health station that cares for individuals in surrounding region. A doctor and multidisciplinary team regular works 1 to 2 times a week with 1 family doctor and a team responsible for 8 to 12,000 people. Telemedicine is a service concept that we offer for chronic and well-controlled illnesses. Patients will see doctors 2 or 3 times per year at health stations. This service covers around 30 to 50% of non-communicable disease. This program is to increase patients' access while simultaneously reducing hospital congestion. The 3-doctor project is a project for seamless care of Thai people. The basic idea is that each Thai household will have 3 personal doctors. The first of whom is the village health volunteer. who lives nearby and will screen and consult with approximately 10 to 12, 10 to 20 families. The second is public health doctor, and the third is doctor, who is accountable for 8 to 12,000 people. We have health projects that aim to enlighten people about their various health problems, such as project to reduce teenage pregnancy, project to combat childhood obesity, project for screening for non-communicable disease, diabetes, hypertension, and also cancer, and also project for aging for elderly. For example, project for promote maternal child health to find new pregnant women to go to prenatal care before 12 weeks of gestation. Project to promote, educate, encourage teenage about teenage pregnancy. Project for school-age children for good height proportion and for reduced childhood obesity. Project for screening for cancer for the most frequent cancer in Thailand, colorectal cancer in males and breast and cervical cancer in female. And also project for elderly screening for screen for elderly specific problem, and elderly problem will be cared at elderly clinic, and health promoting program for elderly such as elderly school. We have home visiting program to provide medical service at home for the whom disadvantaged. For elderly who have dependent condition, we have long-term care program to provide help in the community for dependent people who are registered. They were cared by caregiver and the care manager who were trained. The District Health Board. District Health Board is an organization that consists of cooperation of all three parties: the administrative sector, the public health sector, and the private sector. Representative of the peoples in the region and integrated people-centered care for health support and prevention. For example, in this year, District Health Board also developed road safety program, especially for adolescents to prevent traffic injuries, as well as smart ambulance, smart emergency room to reduce loss and death from traffic injuries. District Health Coordinating Committee is a committee that consists of coordination of hospital, health center, district public health, and a unit of health that provided health service in various levels. The hospital director as a chairman, and the committee was selected equally from the hospital and district public health components, and their meeting schedule meeting schedule are to held every 3 months. The framework authority and the role of the DHCC is to create action plans to improve health in the area, set guidelines and goals operation for health in the area of responsibility, to allocate health resources to public health service center, and also supervise, monitor, evaluate, improve, and correct local health operation. In conclusion, from primary healthcare, we find out area problem to create health promoting program by using community measure and coordination to do this action, and also use more technology to increase patients' access and also increase connectivity. The third part, I will talk about the financial healthcare system. In this part, I'd like to thank you for the data from Dr. Ponsak, who are the Chief of Health Insurance Group. The hospital is being funded by Healthcare Financing as shown. The three main fund is National Health Security Office or NHSO that covers about 84% of population. The second is Comptroller General's Department or CGD that covers about 6% of population. And the third is Social Security Office or SSO that covers about 9% of population. Next, I show about the difference of each fund, such as the source of finance. The source of finance of SSO is from tripartite contribution, and the source of finance for CSMBS and UC from tax funding. And I will show the description later. For civil servant medical benefit scheme, is beneficially for civil servants and their dependents, has the payment method in the form of fee for service for OP outpatients and DRG for inpatients. This fund was financed by tax fund. And for SSO is that cover for private employees. The source of finance from tripartite contributions, employer, employee, and government. The benefit package including maternal care and dental care, and the payment method in form of capitation for outpatients and inpatients, and also other DRG for inpatients. For the third fund is Universal Coverage Scheme. It's public contracted model. It's the most cover the most of population. Was funded by tax. Has the payment method in form of capitation for outpatients and prevention and promotion, and other DRG for inpatients, and the other global budget for fee schedule and high cost and procedures. The benefit package including prevention and promotion and accredited alternative medicine with an exclusion list of some service. The flow of service is that the provider reports data to purchaser and then regulate the form and form the provider report data to purchaser and then regulate the form and to form and service to the patients. Ideally, in the future, we are intention to send all the information about the medical finance to each fund to the financial data hub, but now we are just sending health financial information from only the NHSO to the financial data hub. In the fiscal year of 2023, we show the revenue from each fund. From each fund, we have revenue from the UC only 48%, but we service for outpatients and inpatients for 70%. For SSO, we have revenue about 18%, while we service for outpatient and inpatient 10%. And for CSMBS, we have revenue 17% from the all revenue in this year. This data may show the unbalance of the revenue of the service and the service for each fund. About 140 million from the UC, the primary revenue from the UC, which is split among the capitation for OP, PP, and IP. The remaining revenue is derived from providing service specialized care such as accident and emergency for high cost, and the other for service for specialized group for prevention and promotion, as well as depreciation cost for building and medical investment. For the SSO fund received approximately 57 million in revenue from the capitation of outpatient and inpatient. Utilizing related payment, the additional payment for high-cost medical service and for chronic disease and for prevention and promotion, and the other for workmen's compensation fund. The challenge for provider is the demand for adjustment payment method while containing cost and ensuring access to quality care. For beneficiary side, demographic and epidemiologic transition, and also demand to meet their needs and rise more. Financial side, cost escalation while government budget tend to be limited. I think the all challenge should be balanced. Finally, I would like to thank you to everyone to your attention and your time. And if you have any question, please feel free to ask. I will try to answer as best as I can.